Welcome to The Explainer. Today, we're diving into a massive, honestly fascinating paradigm shift that's happening right now in the world of orthopedics. For decades, total knee replacements have followed a very strict, standardized playbook. But what if the gold standard we've trusted for so long is actually leaving a huge chunk of patients behind? Today, we're going to unpack how a brand new, highly customized surgical philosophy is totally challenging the status quo. It's aiming to take knee replacements from this rigid, off-the-rack procedure into a perfectly tailored fit. Okay, let's dive into this. Here is our roadmap for today's explainer. First up, the 20% problem. Second, the mechanical alignment standard. Third, the kinematic alignment challenger. Fourth, we'll look at the potential risks and complications. And finally, what the clinical studies actually reveal.
Section 1. The 20% problem.
So let's take the UK, for example. Over 100,000 total knee replacements are performed there every single year. It's an incredibly common procedure, right? It's designed to relieve the agonizing pain of end-stage osteoarthritis. But here is the staggering statistic. Up to 20% of those patients are just not satisfied with their outcome. Think about that for a second. That's 20,000 people every single year who undergo major invasive surgery and just don't get the relief they were hoping for. And it's the everyday activities that are causing the real frustration. Despite all our crazy modern technological advancements, these unsatisfied patients are left dealing with glaring issues. We're talking restricted knee flexion, meaning they literally can't bend their knee fully. They still have residual pain. They experience limitations just walking on a flat surface, let alone walking up an incline. And they have a really hard time pivoting. When you can't trust your own knee to pivot, it completely changes how you move through the world. The functional outcomes can be, frankly, pretty disappointing, which forces us to ask, why exactly is this happening?
Moving on to Section 2, the mechanical alignment standard.
Let's rewind a bit. Back in the 1970s, an era not exactly known for great tailored fits, right? The Freeman-Swanson prosthesis was developed, and its main goal was prioritizing mechanical stability over restoring the native anatomy. Fast forward to 1985. A surgeon named Insaw popularized what we call the mechanical alignment technique, or MA. And ever since then, MA has been the absolute, unquestioned gold standard for knee replacements. The whole goal of MA is really simple and reproducible. Just create a perfectly neutral, straight lower limb alignment to balance the load evenly between the inside and outside of the knee. But here is where we hit a massive biomechanical roadblock. So the crucial point is this. Only 0.1% of patients naturally have a perfectly neutral mechanical axis. 0.1%. Sure, the mathematical average of the entire human population might be neutral, but individual variation is absolutely huge. So what does this mean? It means that by using the mechanical alignment standard, surgeons are inevitably altering almost every single patient's native natural anatomy. Basically, think of mechanical alignment like buying an off-the-rack suit. It's cut to one standard dimension. To make the patient's leg actually fit this standardized straight axis, surgeons often have to perform what are called soft tissue releases. Now, this involves technically difficult cutting or stretching of the ligaments just to balance out the joint. And while, yes, this can increase stability, it fundamentally alters the natural kinematics, the natural native movement of the knee. Which brings us to Section 3, the kinematic alignment challenger. Thankfully, because implant technology has improved so dramatically over the years, the old issues of parts wearing out or loosening have largely vanished. And this has opened the door for a revolutionary new surgical philosophy, one that asks, hey, instead of forcing the knee to be perfectly straight, what if we just restore the patient's original anatomy? This is the challenger, kinematic alignment, or KA. Let's compare them directly. While MA forces a standardized neutral axis and requires those soft tissue releases we just talked about, KA aims to restore the patient's highly variable pre-arthritic joint lines. So if MA is that off-the-rack suit, KA is the perfectly tailored bespoke suit. And the best part? Because you're matching the patient's original bone structure, you generally don't need to do any of those difficult ligament releases. And this brilliantly illustrates the biomechanics behind the theory. KA focuses on 3 specific kinematic axes of the native knee. You've got the longitudinal axis in the tibia, that's what the knee rotates around, and the transverse axes in the femur, where the tibia and patella flex and extend. The whole key principle of KA is that by perfectly restoring these exact, specific axes, you improve the patient's gait, the natural feel of the knee, and their overall range of motion.
To actually pull this off, KA is treated as a true resurfacing of the knee joint. The surgeon's goal here is for the artificial implant thickness to replace the exact millimeter for millimeter amount of diseased bone and cartilage that was removed. You aren't building a completely new knee. You're essentially just putting a brand new surface on the patient's original unique knee.
Now, you might be wondering, what if a patient has a severe natural deformity, like a really massive bow leg? Recreating that exactly might actually cause the new implant to wear out unevenly. Well, surgeons thought of that. That's why they developed Restricted Kinematic Alignment, or RKA. It's basically a hybrid protocol. The surgeon still aims for KA, but they restrict the bone cuts to stay within a 5 degrees safe range. It's a really smart, calculated backup plan for patients whose anatomy might just be a bit too inherently unstable. But pulling off this level of extreme customization requires some serious technology. You literally cannot just eyeball it. Step 1 involves taking 3D MRI or CT scans to build a completely unique surgical plan for that specific patient. Step 2 uses patient-specific instrumentation, like bespoke 3D printed cutting blocks, or even advanced robotics to guide the surgeon's hands. And finally, Step 3 involves manual caliper verification right there in the operating room to ensure the exact, precise right amount of bone was removed.
Section 4. Potential risks and complications. Now we have to look at the other side of the coin. There are two major theoretical fears here: compartmental overload and implant loosening. Critics, who are largely relying on computer modeling, by the way, worry that restoring a natural varus, or bow-legged alignment, is going to overload the medial side of the knee and cause the implant to fail way too early. But the actual clinical studies are telling a vastly different story. Intraoperative tests show the forces in KMA knees are remarkably comparable to standard alignments. And when we look at actual varus implant loosening in KMA patients at 2 to 10 years out, it's incredibly low. We're talking just 0.3%. Another valid concern revolves around the kneecap, the patellofemoral joint. Does changing all these angles affect how the kneecap tracks? Well, studies show that both the traditional MOA and the customized KOA replacements actually have a tendency to slightly understuff this joint. But here's the kicker. Recent randomized controlled trials and massive meta-analyses found absolutely no difference in instability or complications between the two methods. So, with contemporary implants, KOA appears to be highly safe.
Finally, Section 5. What the studies actually reveal.
Now, what's really interesting about this slide is that when we look at the high-quality randomized controlled trials, there is no clear knockout punch. The results are surprisingly mixed. A major study by Dawsett showed patients had significantly better functional scores in flexion with KA. But if you look at trials by Watterson and McEwen, they found absolutely no significant difference between the two techniques across multiple scoring systems.
So why is there such a discrepancy? Well, mostly because the current data has some pretty notable flaws. Many of the older studies relied on 2D long-leg X-rays to measure alignment, which are totally prone to rotational errors, rather than using accurate 3D imaging. Plus, some studies claimed to test KK but actually performed a hybrid pseudo-KK. And perhaps the biggest issue, patient scoring systems often hit what we call ceiling effects. This basically means modern surgeries are generally so successful that nearly everyone scores at the very top of the survey anyway, making it statistically impossible to distinguish the good standard outcomes from the great customized outcomes.
Because of these methodological hurdles, the scientific community is remaining firmly objective for now. As the source literature concludes, further high-quality multi-center randomized controlled trials are needed to establish whether KA provides better function and without adversely impacting implant survival. So, before definitively crowning kinematic alignment as the new gold standard, the medical world just needs more standardized, bulletproof data. But look, the momentum here is undeniable. We're moving away from treating the human body as a standardized machine and moving straight towards precision, bespoke medicine. Which leaves us with a totally fascinating question. As robotic tech and 3D mapping continue to advance at lightning speed, if you ever need a joint replaced, will you settle for an off-the-rack standard, or will you demand a surgery perfectly customized just for you? Thank you so much for joining this explainer, and as always, keep questioning the standards.